Hi, everyone. Welcome back. Today, we're joined again by Dr. Stenehjem to give our weekly COVID-19 update to the community. We're going to be going over case counts and some information for the upcoming holidays. Dr. Stenehjem, as always, thank you for joining us.
Thanks for having me, Amanda.
Of course. So let's talk about case trends first. We're going to be going over data that was released yesterday, just so everyone knows. We have a total case count of 110,640. Our rate yesterday with cases was 1,837, which brings us to an 18.1% 7-day positive rate average. We have a total of 598 deaths in the state, and our hospitalizations total is 5,139. Our daily rate for hospitalizations yesterday was 317. Eddie, let's break those down a little bit. How are the hospitals doing? How are you doing in your teams? What do you want people to know about what you're seeing right now?
I mean, pretty depressing numbers, what you say. And I wish I had something good to say about our current situation, but I don't. Yesterday we had the second highest case counts that we ever had. Our hospital numbers continue to skyrocket. And so, we have just here at IMC well over 50 patients with COVID-19. That number continues to go up, and we continue to do load leveling across our system. So, one of the challenges with our ICU numbers in one particular facility is you have to put them in context of all of our facilities. So we've got 23 hospitals, and we're able to move ICU patients and COVID patients that are on the floor to all of our different facilities to make sure that we're all coming up at a pace that's similar, right? So that Utah Valley is not getting overloaded while IMC or McKD is empty. And so now what you see when you look across at our numbers at our hospitals is that all of our facilities, and especially the COVID treatment centers, have really high numbers of COVID-19. And so when you look at, unfortunately, I've read some of the comments on social media, and they say, oh, this is just kind of standard for this time of year. When you look at our occupancy of our hospitals and our ICUs, we're at about 130% occupancy compared to this time last year. And then when you look at COVID cases versus non-COVID cases, our non-COVID cases are down by like 80%. And so that delta of 50% going 80% to 130% is all COVID related. And what we're seeing is that those COVID numbers continue to rise, and we are well over kind of our target occupancy for this time last year. And all of our ICUs and not just our ICUs, but our floors are, getting really, really busy with COVID-19 patients. And
can I ask you a quick question about, so you mentioned load leveling. If someone were to go into a hospital right now and they're not a designated, and I know we don't really have designated facilities, but like an area we're taking care of a lot of COVID patients, is it possible that the waiting rooms are empty? And also, even at like Intermountain Medical Center, if you walk into an ICU unit, or not a unit, but like a waiting room, you're not going to see like thousands of people, right?
No, because you can't have visitors. And so, if a passerby comes in and walks in the hall, they're not going to see hundreds of family members milling about in a waiting room because our ICUs are full, because the patients can't have visitors. And so, that's part of the reason why, people walk by and they're like, oh, the parking lot's not full. Well, it's not full because nobody's here visiting our patients. Yeah, so it can be very misleading to the untrained eye in terms of, true volume. And what is really kind of frightening is that, we know hospitalizations are delayed 7 to 10 days from cases. And so the cases that we were identifying yesterday, those people aren't going to hit our hospital for another week to 10 days. And so, when we look at our Intermountain hospitalization numbers, and we see a continued upward trajectory with the highest numbers we've seen yesterday, we know that trajectory isn't going to change, regardless of what we do in the community today or tomorrow. Our hospitalization numbers are reflective of cases 7 to 10 days ago. And so we're going to continue to have increased hospitalizations in our hospitals. And it's at pace to be an unsustainable rate for us to handle all these cases.
And in the last 2 days, it's been reported that we've had 10 deaths, both reported yesterday, Thursday, and Wednesday. Can you explain the delay from the cases to the hospitalizations to the actual person unfortunately passing away? What's the time frame usually for something like that?
Yeah, so you get diagnosed as a case, and then typically it's 7 to 10 days later where you potentially hit the hospital. And then once you're hospitalized, it's typically another 7 to 10 days, before you would die, sometimes even longer. And those are people that are seeking care in hospitals. So both hospitalizations and death are what we call lagging indicators. And so those are indicators that come much later in time than a case count. And so, yeah, death, the fact that there were 10 were reported yesterday doesn't surprise me at all. I mean, it's tragic, but it's the nature of what we're going to continue to see as we move through this current phase of our epidemic.
Another concern that I keep seeing on Joel about our ICUs is that you mentioned the capacity differences, but that a lot of the reason our hospitals are full right now is because of delayed care. Is there any truth to that statement that all of a sudden we have this huge influx of patients because of delayed care from March, April, May?
No, I mean, there are patients that we see that are being admitted to the hospital for some end stage disease because they didn't want to seek care this summer, for example. Those are the minority. They're not overwhelming our facilities. We're also not bringing tons of surgical patients back in because we put a pause on elective surgery this summer. And those are people that are filling the hospital. No, I mean, when you look at our non-COVID cases, those numbers have actually declined as a percentage compared to this time last year. And that's really because I think our surgeons and our teams are just being much smarter about scheduling surgeries and trying to identify people that potentially could wait so they don't, hit our hospitals. And right now we're doing surgeries as planned, but, and this is a big but, we're going to have to adapt with our case counts. And so we certainly don't want to put a pause on non-urgent surgeries, but that day is coming for us to have to do that again to be able to accommodate the patients, because many people have surgery and then stay overnight in the hospital. Well, that takes up a bed, and that bed potentially is going to need to be used for a COVID-19 patient.
I want to switch subjects a little bit to ski season. We're in Utah. It's going to be here before we know it, hopefully sooner than later. And the ski resorts have come out with some precautions about how they're going to be handling it, from reservations to limiting time in the lodges and everything like that. But how can people protect themselves? Should they be bringing an extra mask with them outside of their normal ski buff that they wear to wear in the lodge? What are some of your suggestions for people with that?
Right. So good on the ski resorts to do everything that they possibly can to stay open to serve our Utah communities. We're going to need to get outside. We're going to need some fresh air. I know that, I mean, speaking for myself, and I'm hoping that, ski resorts can be a safe place to go and recreate and kind of get that stress relief that we need. In my mind, the highest risk area for a ski resort is the lodge, period. Hands down. You come in, you're hot, you're yelling, you're talking with friends, you're in a small crowded space. That's your high risk spot, is the lodge. And so, fortunately, we're locals, we're Utahns, and so we don't necessarily need to use the lodge. And so I would say, number one, first and foremost, if you can avoid the lodge, avoid the lodge. Okay. Try to, support them in other means. If you want to, get food and beverage, these resorts are going to be setting up outside dining services. Utilize that. I would just really minimize your time in the lodge as much as possible, and stay outside. Dress appropriately and stay outside. I think bringing an additional mask while you're in the parking lot, while you're getting ready, I think is a good idea. The act of skiing is you're outside, and typically your face is covered. And this year, everybody's face is going to need to be covered, whether it be through a ski buff or your jacket, whatever it might be. That's going to be critical. And then they'll be putting in precautions in terms of the lift lines and how they operate their chair lifts. But in all honesty, I think if you're on a chairlift, you're moving with speed, you're outside, it's typically windy, and your face is covered. That's a pretty low risk, a pretty low risk area to be in, and a low risk for transmission. So I'm hoping that the ski resorts are going to be able to have a nice long season this year. I think their biggest liability is their staff. And so ski resorts are staffed in general. I did it when I was in college. I mean, I worked in a kitchen at a ski resort. Is their staff and the way that their staff congregate together. So typically ski resort staff lives in high density housing, whether it be apartments or houses. There's a lot of them packed together. They like to go out. They like to socialize. That's the risk right there, is that if their staff start getting sick, are they going to have enough staff to support the operations of the ski resort?
I also worked at a ski resort, and yes, we all do like to hang out. We become like a little family.
Right.
You mentioned not going in the lodges, and this is just a suggestion from my personal perspective. But if you had a season's pass, you could plan to go from like 9 to 1 and leave and not eat lunch there, or eat lunch before you get there, or bring it with you. I know there is lots of outdoor spaces and it might be cold, but hopefully that allows people to enjoy the ski season. And another concern is, what about public transportation? I don't know how they're handling the buses system. I know parking is very sparse up in the canyons. Any suggestions for how people handle public transportation for getting up to the resorts?
Yeah, it's a really good point that you brought up, just because as the canyons were pushing more and more people to public transportation last year, a bigger focus on busing, Solitude starting to charge for parking appropriately to try to encourage people to carpool. Now, carpools and buses are, potentially at risk. And so what I'd hope to see is that, one, they increase the number of buses to decrease the density of people on the buses. You decrease the number of people on the buses as well. And all those windows on the buses are open. And everybody is required to wear a mask and an effective mask on the bus. And so I think if those precautions are put into place by the Utah Department of Transportation, then I think, the buses would be a relatively safe endeavor for us to continue to utilize. I would say if you're going to be carpooling, that everybody has to be masked in the car if you're not immediate family. And then if you are carpooling, windows down, increase the ventilation in your car. So I think there's safe ways to do it. That said, we're going to have to be really strict precautions to public health measures if you're traveling with people other than your family.
I have a question about the carpooling with people. There's a lot of people that I hear that I follow that talk about these quarantine bubbles of people that they kind of have in their pods. If you have someone in your pod who you've discussed precautions with, they're taking the same measures with you, do you still need to wear a mask in that type of situation? Or are you okay since you've kind of developed this quarantine bubble?
Yeah, I hear a lot about quarantine bubbles, quarantine families, those types of things. And it really is dependent on how strict each member of those pods or families are abiding by public health measures, right? So if you have somebody in your pod who goes to work and doesn't wear a mask at work, or their whole, office doesn't wear a mask, and then comes back into your pod, well, you're all at risk, right? But if you have another family who works from home, who doesn't engage with other people, and you don't engage with other people, and you're 100% masked all the time, well, those risk levels are much lower amongst that, and you could potentially make that decision to not wear a mask. I'd say the way people are moving in the community right now and the level of risk in the community is everyone's at risk, period. So it's a really challenging time right now to have kind of safety pods or COVID pods, just because everybody's at risk, unless you're being, 100% diligent in terms of decreasing your social contacts and wearing a mask. And so I wish it was black and white, but it's not. It's all dependent on how each individual person abides by public health measures.
I want to switch back to hospitals really quick. We got a couple of questions. Someone wants you to address a rumor. And this is what this person said. There's a lot of rumors of people from other parts of the hospital being wheeled into the ICU to give the impression that ICU beds are full. Can you address that? I haven't heard that.
I mean, I don't, do people think that I'm lying to people? Do people think that our hospital ICU doctors are out there pleading with the public because we want attention? I don't get this idea of deception from the healthcare workers. We're here to take care of the community, period. We're not benefiting from this,
right,
this epidemic. We're just trying to care for people that come into our hospital. So if you think we're rolling people in the ICU to cause our numbers to be up and somehow we're benefiting from that, give me a break. Like, have a little more respect for our profession than that.
And I mean, you have a family. I don't think you want to keep yourself away from your family more than you have to. So hopefully that cleared it up. One more question about hospitalization. Someone asked if we can begin treating patients potentially in their home with home nursing and respiratory prevention therapy to keep our hospital capacity down. Is that something that the country has thought about or the Intermountain has thought about? Do you have any thoughts on potentially moving people to outpatient treatment, essentially?
Yeah, so really good, timely question. So yes, so a couple things to unpack in that question. We are looking at how do you get people that are admitted to the hospital with COVID-19 home quicker? And one of the methods to do that is something called hospital at home. And that's where we essentially send them with a pulse oximeter, and we have daily interactions with them via technical modalities like this. And it's a way to get people in, identify their stability, be convinced that they're not going to decompensate, and then send them home with some level of monitoring so we can decrease the length of time they're in the hospital so we can accommodate more patients. So that's one method that we are actively pursuing and exploring, and Intermountain Hospital at Home is going to be able to accommodate some of those patients. And so that's one. The second one, which I think the question alludes to, is is there a treatment modality we can implement in the ED or urgent care in people that are positive for COVID-19, that have mild to moderate disease, that don't need to be hospitalized, to prevent them from needing to be hospitalized? And so there's two drugs that are currently being looked at for this, or two types. So remdesivir is the drug that's been studied through the Solidarity study or Act 1. And we're looking at outpatient treatment with remdesivir, so intravenous remdesivir every day for 3 days as a means to potentially, reduce the hospitalization rate. That's right now is just under NIH study protocols, and we don't know if that works, but that's a study we have here at Intermountain. We are hopeful for that. Probably the thing that we're most hopeful for is something called monoclonal antibodies. And so these are antibodies that we develop in the lab that target specifically a particular protein on SARS-CoV-2 on the outside of the virus, that if somebody were to come in early in their course, have high risk features of potentially doing poorly, we give them this monoclonal antibody, and that potentially prevents hospitalization. Two companies are actively looking at that, Eli Lilly and Regeneron. Regeneron has filed for an emergency use authorization based on some data in this outpatient sector that may do exactly what we just talked about: reduce hospitalizations, reduce healthcare visits in people that are positive, especially if they're earlier in their course. That we're optimistic about. The challenge about that is that there's just not going to be that many doses available, even if the FDA grants an EUA. And so I've seen estimates of 50,000 doses worldwide of this drug. That's going to increase as time goes and production, gets online. But it's a very viable treatment option. But I just don't think it's going to be widely available anytime in the near future.
It sounds like, yes, those things could happen, but we should not rely on that to keep our hospital capacity down. A couple more questions from you from the Facebook Live. Someone wanted to know, they're living with someone who is currently COVID positive. They have all the symptoms and they've tested negative twice. How accurate is their testing? Should she be retested? She said she's quarantining and staying home. I think we've mentioned this before, but I think you've said that it's possible for you to not get COVID if you're exposed to someone, correct?
Yeah. So in terms of whether or not this person is positive, it depends on the kind of tests that they had. And so if they had a PCR test, those tests are really quite good versus an antigen test, which those tests aren't as accurate. It also is really dependent on when this person got tested in terms of their symptom onset. And so we know that your highest infectivity, meaning the highest viral burden in your upper respiratory tract, the 2 days before and the 2 days after symptom onset. And so if somebody's being tested 7 days after symptom starts, there's a chance that that may be a negative test just because their viral load is so low in their upper tract. So that's something to be thinking about, and whether or not they had a PCR versus an antigen test. Antigen tests are good, especially in low risk people, but somebody with high risk symptoms of disease, those people really would benefit from a PCR test. And so there's some big caveats. I would also say that if somebody has signs and symptoms of COVID-19 and they test negative, in my mind, that's still COVID-19. When we look at our respiratory surveillance across Utah within Intermountain Healthcare, there aren't any other viral respiratory pathogens circulating. We haven't seen influenza, we haven't seen rhinovirus, we haven't seen any other viral respiratory illnesses. So if somebody has a viral respiratory illness with fever and cough and myalgias and things like that, that's COVID, regardless of what your test says, because there's nothing else circulating. In terms of what is the risk to that individual, it all depends on their exposure and their types of exposure. You know, when you look at transmission rates in the home, there's a lot of studies out there, and they range in general between about 5% and 30% transmission rate to people in the home. So is it guaranteed that you get COVID-19 if you're caring for somebody in the home? No, it's definitely not a guarantee. Especially if you're taking precautions. Like, can that person quarantine in another room? And then if you do interact with them, are you wearing a mask? Are you washing your hands? And so it definitely is not something where you just throw your hands up in the air and say, like, I'm going to get it. It's definitely worth taking precautions because it's been shown that it's not a guarantee.
You mentioned the flu. I want to touch on that really quickly. You mentioned we're not seeing the actual virus circulate yet, but have we been testing for the flu at all? Are we still going to be reporting out influenza cases this year? Is there a difference between the two? There's been other rumors circulating around the CDC not reporting influenza data, which I did find this morning, so I can link that below for anyone who's interested. But is Intermountain reporting, or not reporting, but recording the cases of flu and influenza that come in this year?
Yeah, absolutely. So the influenza epidemiology is going to be really important for us as a healthcare system for a number of reasons. And so to answer your first question, if you look at the month of October and compare it to 2019 October, our rate of influenza testing for this month is up 450% compared to last year this month. And so the question is, are we looking for it? Yeah, absolutely, we're looking for it. Because these people come in, they look like influenza. And so we have to rule out influenza, especially as we're moving into the season, because influenza has specific treatments that we need to give patients that make them better. And so are we looking for it? Yeah, 100% we're looking for it. And what we're doing is we're tracking our influenza cases per week, because once we start seeing flu in our community, that means that the Instacares or community-based care clinics, our EDs, have to routinely be checking for influenza when somebody comes in with an illness similar to COVID, because the treatment path for influenza is different for COVID. We need to get people with influenza on Tamiflu or oseltamivir, whereas people with COVID get a whole different treatment paradigm. And so we have set up a system where we are monitoring and tracking all of our viral testing results every week. It's done daily, but we're reporting those out, or we will be reporting those out weekly to all of our caregivers, for them to know when we start seeing influenza in our community. And that's going to be a trigger for them to say, okay, in the community, I need to either be testing for flu or treating empirically for flu. So it's really a hot issue right now, and one that we're actively monitoring aggressively.
We have a lot of questions from the live. I'm just going to pick a few more, and then I'll go back to a couple of other ones. People wanted to ask about the antibody testing, and someone specifically mentioned that we should do more antibody testing so people can stop living in fear. Do you want to talk about the fact that it's not a guarantee if you have the antibodies that you won't get it again, and just the reliability of those tests, which you kind of spoke to earlier?
So an antibody test after acute infection is typically positive after 14 days from symptom onset. Okay, so that the way we're using an antibody test in healthcare is an alternative way to make a diagnosis kind of post hoc, meaning somebody comes in, they've had symptoms for 10 to 14 days, they're sick, they look like they've got COVID-19, their tests are negative. Those are people that we do an antibody test to see if it's positive, to make that definitive diagnosis that, yeah, that really is COVID-19. That's about the only clinical application for the antibody test as it stands right now in healthcare. Antibody tests are very good for seroprevalence studies. So going out to a community, randomly selecting people in that community, testing them for antibody to see how aggressively the virus has spread in our community. Okay, so those are the two: clinical application and kind of a research public health application. I think what this person is kind of thinking about is herd immunity. Okay, so this is a complicated point, but one that we need to think about. Think about other seasonal coronaviruses. Okay, these are coronaviruses that we get every so often. They cause upper respiratory infections. These are things that cause the common cold, right? Everybody has had coronaviruses, seasonal coronaviruses in the US. So I would ask you, Amanda, if everybody's had them and they probably have antibodies, well, why do they keep getting them, right? Isn't that the whole point of herd immunity, is that everybody gets the infection and then nobody gets it anymore? Well, the issue with coronaviruses is that you can get repeat infections, right? And so herd immunity, by having everybody get this infection with SARS-CoV-2, knowing that you can get it again, is not a logical way to move forward. That would mean everybody get it, and then everybody's going to be at risk to get it again in a year or two. And so, herd immunity and having a positive antibody test, doesn't get you much aside from just knowing that you've already had it at once. I can tell you, we've already seen patients in our hospital that have been reinfected. We had an individual that tested positive with mild disease in June, completely normal, asymptomatic, and then came back in and had to be hospitalized because of COVID-19 pneumonia. And we didn't find any other explanation besides reinfection. So we know people can get reinfected with this. And so having a positive antibody response doesn't necessarily protect you like people hope it would. And so I get it. It'd be nice to be able to say, like, okay, I don't have to live in fear because I've already had it. But unfortunately, you're likely going to be able to get it again. We just don't know enough about the immunology of this virus to just say, how long are you protected, or are you at all protected? And so it's that herd immunity approach is not one that we need to even be considering right now in Utah.
And they mentioned the term specifically, living in fear. I don't think anyone needs to live in fear of COVID-19. I just think you need to take the necessary precautions to protect yourself, your family, your loved ones. I don't think it should be this fear-based trigger that makes you wear a mask or wash your hands, but just the common decency and understanding that that's one way that we can make sure that we don't overload our hospitals. So I don't think anyone's trying to push fear on people. So hopefully the person who asked that knows that it's not a fear thing. It's just a public health thing. Quick question, just can you reiterate the no other virus is circulating? Someone said, so the cold's not circulating. You specifically mentioned upper respiratory. Can you just explain what that means for people so that they understand that you could probably still have a cold right now, but it's not something related to COVID-19?
Yeah, well, so we have a number of different testing platforms within our hospitals and clinics that test for many of the standard upper respiratory viruses. These are called the respiratory viral panels. And we can track, how often those are positive across our system. And that gives us an idea, and it gives our community clinics an idea of what's circulating. So you can then, educate the public when they come in with signs and symptoms of parainfluenza or RSV, for example. When we look at our data right now in terms of upper respiratory viruses, by far, SARS-CoV-2, the virus that causes coronavirus, is the predominant virus. We see low levels of other viruses, but in comparison to COVID-19 or SARS-CoV-2, they are very, very low levels. And so the one major respiratory virus that's circulating right now in our community is SARS-CoV-2. And so if you have a cold right now, you have to assume that that's SARS-CoV-2 and you need to get it tested, period. We can't differentiate. And we know that in younger people, that many times this virus will either be completely asymptomatic or just show up as a standard viral URI. And so at this point, if you have a cold symptoms, that in my mind is SARS-CoV-2 until proven otherwise, and you need to go in and get tested. And that will likely change as we move into the winter months. We'll likely start seeing more cases of rhinovirus, more cases of RSV in children, more cases of paraflu, human metapneumovirus, all of these other viral infections. But right now, we're not seeing really anything else.
That's good to know. I'm going to switch gears so that we're not here for 2 hours. We're going to talk about the holidays. Halloween is tomorrow. What is your message for people that are still planning on going out and about in the community?
Yeah, I think, and Angela hit on this a couple weeks ago, is that what I worry most about Halloween is not the trick-or-treating per se. I worry more about the events before that and after that. So families getting together to see kids getting dressed up, or getting together afterwards to go through their candies with other families. Those are those high-risk environments. The transmission rate right now in Utah is so high that you have to assume, if you're coming into contact with other people outside of your immediate family, you are at high risk for being exposed to this virus. And so it's those types of gatherings before and after that are going to be really high risk. I think if you're outside trick-or-treating, I think you can certainly, implement some protective measures, right? So stay within your group, be really cognizant of having small groups, let somebody go up to the door, come back before you go up, incorporate a mask. Everybody has to wear a mask trick-or-treating. So incorporate your mask into your costume. And then, make sure you do good hand hygiene when you get home. Some people even advocate for kind of washing off the candy when you get it. So I think the actual act of trick-or-treating is probably relatively safe as long as people have small groups and wear a mask. But it's the before and after that I think are really going to be potentially problematic. And if you look at each holiday that we've had, whether you look at Memorial Day or Labor Day, Mother's Day, we've seen spikes afterwards. And so, we really can't accommodate another spike at this point.
Speaking of holidays, Thanksgiving is also in less than a month. I just want to get a couple of recommendations from you, and we can talk more about this in detail next week. If you are going to be having people in your home that are not your family or not the people you live with, should you be having an indoor or outdoor gathering? And do you even recommend gathering with people who don't live with you?
Yeah, this unfortunately, our holidays are coming at a terrible time for us. And I say that because, our cases that are an all-time high. and are continuing to go up. And I don't see any change in that. I don't see us, having a dip in our curve anytime soon, just because nothing's changing in the community. And so if you are bringing in other people into your home, if you're bringing in a large family gathering, that will be a super spreader event. That will be an event that will transmit and get people infected with coronavirus. And especially if you're having older people, mothers, grandparents, father, whatever it might be, they're going to be at risk. And so, unfortunately, it just like everything else in this pandemic, it's going to be self-sacrifice to say, listen, now is not the time to be having large indoor gatherings. And I would even say even small indoor gatherings can transmit the virus. They just don't transmit them as widely as, large gatherings do. So to answer your question, is outside is much more preferable than inside. And fingers crossed, we have decent weather like we did a number of years ago where we can have dinner outside. And then if you're going to do things inside, really, really consider limit it to your immediate family. And know that if you are bringing in other extended family members, you're at risk. You're at risk for transmitting the virus.
What about having someone come travel in too from another state? Are they posing a risk to you if they were to come into Utah?
Yeah, it all depends on the epidemiology of the virus from where they're coming and how well they are abiding by public health measures. So if you have, let's say, a relative that lives in South Dakota or North Dakota that has a test positivity rate of 40 to 50%, and they're coming into your house, and if that person isn't somebody who wears masks or abides by social distancing, yeah, they're a huge risk. But if you're having somebody come from Vermont who has an incredibly low transmission risk coming into your home, well, they don't pose a risk to you. You pose a risk to them because of our transmission rate. And so it's all dependent on where they're coming and what is that individual or family's risk to you and your risk to them.
What about college kids? I know that college kids will be going home, even if they live in state, they live in the dorms, but they're going home for the holidays. What about their risk to their parents? How do you handle that?
Yeah, that's going to be a really tough one. If you look at our demographics of infection here in Utah, the 15 to 24-year-olds are the highest. And so they peaked, they transmitted it to the community. All the other age groups peaks, and now that 15 to 24-year-old age group is still high and maintaining high rates. And so having a college age person come back into your family, puts your family at risk just because of the epidemiology of this infection and that they're at high risk of infection and mildly symptomatic or no symptoms. And then people say, oh, don't worry, I'll get my son or daughter tested before they get in the house. And that's fine, but all a test tells you is that they're negative at that point in time. It doesn't tell you whether or not they turn positive the next day or the next day. And so it really has to be, something that's discussed and talked about amongst the family. And I've talked to many families who said, listen, I've got a college age kid coming back home. I am not going to have a Thanksgiving where I bring in my parents or somebody that's at risk because this college student puts us at risk of infection. And so it really is a challenge. And another way, I've heard is that people will come home early and essentially quarantine. Regardless of how you look at it, that age group is a risk, especially if they're out on college campus socializing and not wearing a mask. Like they're one of the highest risks in the community to then potentially spread to parents and grandparents.
Last question for you. How do we change the course that we're currently on in the state of Utah? How do we make sure that this doesn't get any worse?
If you look at our mask compliance rate as put on the website, overall it's 70% or so. Women do much better than males in terms of wearing masks. If you look at our outdoor mask compliance rate, it's abysmal. It's like 20%, 30%. I haven't seen that change in terms of my interaction in the community. Our cases continue to go up, our hospitalizations continue to go up. We're at a point where we need a big, bold intervention. Us from healthcare pleading with the public to say, look at our ICU, look at our hospital, look at these suffering patients. It's not working, right? We look how much national attention we've gotten. This week we were on ABC, PBS, NBC, CNN, all national news outlets pointing to Utah as like, what the hell's happening there? Look at your case counts. What are you going to do? And yet we haven't seen anything necessarily change. So in my, opinion is we need a temporary pause. We need to go back to those restrictions that we had back in March and April, and we need to drive down the community transmission rate of this virus, period. And so, if I was in that position, I would say this is going to hurt Utah, but this is going to be a 2-week pause where all school goes online. We cancel all sporting activities, all after school activities. Everybody stays home. We close bars and restaurants. They do, takeout dining only to support them. And everybody stays home. And if everybody stays home for 2 weeks, what we will see is that curve plummet back down to a level that we can accommodate in our hospitals and our testing centers and our clinics. Aside from that, I'm not sure what's going to happen. If we continue going on the course that we are, just hoping and praying that things get better, I don't think anything's going to change. So I unfortunately think the time for us to do kind of conservative public health community measures and messaging, unfortunately, I think that's passed. And I think we're going to need a pretty aggressive pause in our life to get that community transmission down, especially as we go into the holidays.
Well, thank you, Eddie. I really appreciate the candid conversation that we just had. And I know there's a bunch of questions we weren't able to get to. We can go through and answer those directly for people later. If you in the public have any questions about COVID-19 or would like to see if you qualify for a test, we have a new way to test people. You do have to have a arrival time to get tested through Intermountain Healthcare. You can go to intermountain.com/COVID testing, and you'll see a chat bot called Scout that will walk you through a bunch of questions related to COVID-19 symptoms. You'll be able to then select an appointment time if you are qualifying for a test. If there are not appointment times available soon or near you, we have a list of the state resources and state testing sites that you can also go to. If you have any questions at all, you can look at that website and see if there's any information for you. We still have our emotional health relief hotline available 7 days a week from 10 a.m. to 10 p.m. That phone number is 334422211. Especially around the holidays, please utilize that number. Our caregivers are there to support you right now. Eddie, again, thank you, and we'll talk with you next week.
Okay, thanks, Amanda.